Good afternoon, everybody. Sorry for the slight delay. It's my pleasure to introduce Dr. Ronit Kishon. She is a psychologist who has worked with our group at Columbia University for many years, and she will be speaking on suicide prevention theories and clinical interventions. And Ronit, you may have a few more things to say about yourself and your work that I have left out. Please add them if you wish. So here's Ronit Kishon.
Okay, Judy, thank you. So hello, everyone. If you see that, whoops, anyway, signal me if there are questions. I don't mind to be interrupted. So anyway, I just moved 2 slides forward and I clueless how to move it back. So you'll have to, I'll talk the 2 first slides. So as Judy said, I'm a clinical psychologist, originally from Israel. I don't know, I think it still shows in my accent. Born and raised in Israel, and had my clinical psych studies at Columbia University at New York, and then came back to Israel and became a trauma therapist. So many people that I've been working with have been honored to work through the years, were in the Holocaust, different wars. Actually, in my internship at United States, I was very honored to work with Vietnam veterans. And as I came back to United States and settled in the last 15 years, I worked a lot with 9/11 survivors and their families. And recent years, I started doing my research. Well, maybe at this point, it's for quite some while at the New York State Psychiatric Institute, and I'm part of Professor Hoven's research group and some other units. So beside doing my best to help people who are either depressed or have post-traumatic stress disorder or bipolar disorder or other things from all walks of life, I am also invested in doing research and understanding how we can help people. I wanted to have a sense of who is here today, but welcome, whoever is maybe later in after the questions, I'll have a better sense. I am going to present to you the psychological aspects of suicidality. I'm emphasizing that because there are many aspects to suicidality. There are psychiatric elements to it. There are socioeconomical elements to it. There are a lot of facets to this issue. So I'll be very focused on the psychological aspects, but also emphasizing that it's a part of a much larger, complex. Everyone talks about mechanisms these days, but I would say human condition. And I think the simple way to say it is that it really needs a village to help people who are suicidal. So all of us need to pitch in and do our work. So I'll start. I'm going to start with some fable and facts about suicidality. There are a lot of things that people know and they think it's true, and it's not so accurate based on the studies that we do. So the first comment here or statement here, all suicidal individuals are mentally ill, and suicide always is the act of a psychotic person. And honestly, that's not true. People do not need to have a mental illness or become psychotic to commit suicide. That does not mean that some people that do have mental illnesses don't commit suicide. Unfortunately, they do. But we have enough evidence that people can become extremely unhappy and unfortunately end their life. Another statement here, suicide is inherited or runs in the family. Not so, not so. Yes, some people who committed suicide had someone else in former generations who did that, but not necessarily. our data shows that suicide does not run in families. It's an individual pattern, which only needs to make us much more aware if someone seems to us suicidal. And we cannot come down just because, oh, it never happened before in our family. That would not work. Suicide strikes much more often among the rich, or conversely among the poor. This is something that I've heard in different places, in different cultures. And actually, it's a very democratic condition, meaning it can strike the rich, the poor, the middle. It really doesn't go by level of wealth. That's not to emphasize that people with lower low socioeconomic level have much less resources to heal themselves. So I don't want to take the emphasis for that, but there are many people that are susceptible. Well, I don't know to say many, but from all walks of life that are susceptible to that. Suicidality is more serious if it's part of an ongoing depression and is often communicated. Well, not so. Individuals who wish to kill themselves are usually suicidal only for a limited period of time, which means we should take their suicidal thoughts and statements seriously. So what we are really saying here, and that will be something I'll keep emphasizing through the hour, that the death and the unfortunate death is just one, unfortunately, last phase of different phases where the person is very ambivalent or undecisive about ending their life. So what it really means that the person is actually thinking to take their lives away in a very particular moment. Sometimes it could be hours, sometimes days, but we can have some years before to prevent that. And that's going to be a big emphasis of my talk. Improvement following a suicidal crisis means that the suicidal risk is over. Now, what do I mean by that? That's a very important thing, which I like to emphasize. Let's say the person has hit rock bottom, very depressed, very something. And they're being walked to a counselor, or the family members take them to someone's home, and they're being attended, and they're being given, whatever care they need, and they're starting to feel better. And then usually the family, the community around these things, okay, danger is over. Well, very unfortunately, no. Most suicides occur within about 3 months following the beginning of improvement, when the individual has the energy to put his or her morbid thoughts and feelings into effect. That's a very tricky psychological component of being suicidal. I mean, one can start feeling better. Well, I'm not sure that's the word. If they would have felt better, maybe they wouldn't have been suicidal, but you kind of see them talk more, less depressed, less something, maybe eating better, and you think, okay, now we can kind of watch them less or something less. The answer is actually now you've reached might reach a very dangerous point, because they may have the energy to go and do what they were unfortunately planning to do. Suicidal people are fully intent on dying, and that's something that, another common thought about people who commit suicide. Not true. Based on many studies that we have been doing through the years, most suicidal people are undecided or ambivalent about living or dying, and they actually gamble with death, and they do leave others to save them. And even the people that did end their life, very unfortunately, and some of, if you think about it, how can you study someone who, how can you study suicidality? At the end of the day, we usually look into what they left. It used to be letters, it used to be notes. Now people, I don't know if to say unfortunately, but do some videos of themselves. So the bottom conclusion is that they want to let the other know something. They are communicating to us. And you wonder if there, even just there and then, there is some level of I would say ambivalence. It's not like some animals that decide that their time to die and they go to the bush, the bushes, and they just die and no one, this is something else that is going on here. And we have strong reasons to believe that there remains always, until maybe a few minutes before, some level of ambivalence about whether this needs to happen or not. People who talk about suicide don't commit suicide. That's many people in different countries think that, he just talks the talk, she's just complaining all the time. Well, unfortunately, of any 10 persons who kill themselves, 8 have given definite warnings of their suicidal intentions and expressed it and talked about it. So I know that there is a belief that the person who wants to kill themselves won't say anything. That may hold for maybe the days before, but that particular person who unfortunately reached that state most likely expressed that before in different ways, which we're going to look at in one moment. Okay, so I'm going to start with initial assessment that we always do of suicidality. I think that has been presented in other talks, so I'm going to kind of do a very short review of that so I can concentrate more on the psychological theories and research. But still, I think it's important to give you kind of a little bit the psychological angle of assessing suicidality. Where am I? Okay. And this is a slide that I always show because that's what, when the attention is cut, that's when people say, oh, we need to deal with suicide. There was a suicide. But what this talk will show, that there are like 300 phases before that happened that we need to intervene. So, for psychologists, suicide is like, it's the horrible end result. It's the result of all the things that maybe could have been done and were not done, actually. So when people talk and study suicidality, it's very important to, of course, study this phenomenon. But the clinician in me always thinks of all the things that needed to happen before on many levels, not just psychological levels. This is a very common question. We ask it, and I'm sure Judy knows about that, in the Hamilton Depression Rating Scale, which is a very common scale that we use for depression. But I actually use often enough this question, even if I don't think the person is depressed, but for some reason, I think she or he may have thoughts of death. And basically, it's just a very detailed, I want to say almost technical or dry question, and I'll talk in a minute about how to present that. This past week, have you had any thought that life is not worth living, or that you would be better off dead? What about having thoughts of hurting yourself or killing yourself? Now, years that my students ask me how exactly to ask this question, and I usually say, you are just going to read it in a serious tone, with some acceptance and compassion, of course, but you can't you can't be in some ways too emotional here, because this is you needing a lot of information. And if you can convey a non-judgmental, caring, neutral perspective, so the person actually sees that you want to know, but also if I'll be overly concerned, I might not get any information. So you basically ask about the last 7 days, because usually that's what people remember about their thoughts and feelings. it can get confusing if you ask about the few weeks. And you really want to detect any thought of this. So it really could be, I don't want to wake up. I wish a car would run over me. It could be anything to that extent. Bear with me. I just need to close something on my computer. Forgive me. Well, I guess I'm not going to do that. Here I go. But you really want the nitty-gritty of the information, and what you're actually doing is you move from what we call passive thoughts, just thoughts of death, thinking if life is worth it, not wanting to wake up, to potentially, well, if I would cross the street and the car will run over me, that may not be such a terrible thing. And then you want to know what, like how often this thought comes to your mind, and did you ever, when the thought comes to your mind, do you find yourself go to this local street and think and literally look at cars, and you do want to get to a stage where you say, did you actually do anything to hurt yourself? So it's really gathering a lot of information in a way that allows the person to discuss it. And I keep saying it's kind of a compassion neutral position. Now, what is an attempt? Attempt to end one's life is actually that there is an attempt to injury oneself, and there was an intention to end one's life. It could be a non-fatal, which that's why we call it an attempt and not a suicide. But if that occurred, and it doesn't matter if it was just taking a bunch of pills that would not even harm a child, this is for us a serious matter, because the person actually not just thought something, but got to a point of a behavior and actually did something. We couldn't care less that the person is basically fine. And we highly recommend to take the person to the emergency room, or at least if this was really a benign attempt, to have someone be with this person for at least 24 hours, if not longer, and get them later to someone who can start treating it. The main things that we concentrate on is whether a person reached an intent, like a desire to do it. There can be a desire and no plan to do it, but there can be a plan. And you also want, and it sounds horrifically simple, but it's unfortunately a reality. You also want to know that what's the environment that the person is in, because you need actually to actually die, you need a knife, you need a gun, you need a bridge. So when the person actually has thoughts and intent, and they seem to have a plan, you really want to know the logistic of this person, the logistics of this person's environment, and you cannot be shy about it. It includes a kitchen knife. You really just want to be very detailed in your questions. Now, the psychological purpose of this, beside hopefully saving someone's life, as you're going to see in a short time from the theories that we have in psychology about suicidality, a person with a wish death, something happens to them emotionally, of course, great intensities, which I'll talk about later, but cognitively, they start shutting down. And they really start reducing themselves to something very narrow. I'm talking about it psychologically. I don't mean to say that death is a narrow thing. And of course, there are many ways to think about death, but I'm very much being a psychologist at the moment. So actually, if you start discussing this with a person, if the person needs to tell you about it, talk about it, you're actually, if the cognitive reduction has started and the person is becoming, tremendously focused and maybe not verbal, you're interrupting that process. So beside knowing the information, because you need to know the facts, you are asking many questions about this specific topic because you want to interrupt that cognitive reduction that might lead to suicide. So that's for me something important, and that's why I always ask to spend a lot of time about this question. And it's not just me; many excellent researchers and clinicians know that there are measures, long detailed measures about suicidality, which is part of, one can say, the beginning of treating it. Um, Once we talk about suicidality, we cannot not mention what's considered the non-suicidal self-injury, the gestures, where the intent was not to end someone's life, but to injure. It's not our topic in some ways, but obviously people that do that have crossed a line as far as hurting themselves. So, you cannot be too calm about, oh, this particular individual, they keep hurting themselves, but it's they're not suicidal, they're not, but they crossed the line. So this is a subgroup of people that you always will check in a very serious manner about their suicidal thoughts and their level of suicidality. Okay, what are the risk factors? So after I said earlier that the person does not necessarily need to have a mental illness and can get to a great despair and their life, I do want to say something. We know, and one doesn't contradict the other. We do know that depression, mental disorders, substance abuse, which I consider a disorder, and post-traumatic stress disorder is something that these people who have it might be suicidal and might end their lives. Let's not forget particular mental conditions. Here in the States, we have a training program at Columbia for clinics that work with HIV positive people, and the rates of suicidality there are still quite high. I'm saying still because there are much better medications, but to say it in short, medical conditions do lead to suicide, so we need to be aware. Chronic pain, this is something that people are less aware, but chronic physical pain can affect some people to end their lives. Definitely, if the person attempted before, he or she are very vulnerable and in position to do it again. Again, some lines that I'll be discussing later were crossed. Yes, family history of mental disorder or substance abuse, as I say, doesn't have to be, but yes. Family history of suicide doesn't have to be, but yes. And this item, family violence, including physical or sexual abuse, which people like me see it usually as a clear indication that some of the family members are suffering from post-traumatic stress disorder, which was not treated. That's unfortunately one of the major things that can create a person to end their lives, whether it's the person who's been abused, obviously, but also the person who abused. And that's why in any place where there is family violence, people like me urge to go into this family and find ways to heal all of them. This is almost, one would say, why would you write it? But honestly, people kill themselves when they have means to do it, and having fire guns or other firearms, or those big huge knives in the kitchen. do the job. So I'm not going to, say that they are to blame, but I always wish we won't have access to these things, although one can argue with me that sometimes it's needed. Um, Having recently been released from prison or jail, that's something that definitely there are higher suicidal rates there, from what we know, from what we study. And that's the last item, and I don't have enough time today to discuss it, but when someone else, whether this person is close to us or whether this person is known to us, it could be a public figure, somehow when we know about someone who did that, for some of us, it's a trigger. And this is something I even remember. I don't know if Judy, I think you were there, that we discussed it in our group one day at Columbia, what that's about. But that also brings into, there's sometimes in social media, someone announces that. I think it's a complex matter, and I'm not going to talk about it, discuss it, but I need to mention it. Okay, before I go to the theories, this is what we call a safety plan. Maybe some of you know it by heart, and if you do, then you know how good that is. This is one of the most simple forms that I've seen that saved, I believe, many people's life. And again, this is all in the context that when a person that we know he or she has suicidal thoughts, and at the moment they're in our office or we are in their homes and they're discussing it with us, they may reach a point where their negative emotions will be so intense, and their level of cognition will be so narrowed down, or as my mother would say, they will be out of their mind, no offense for the expression, that you don't expect them at that point to think what to do. And this, what we call safety plan, is a form that we usually do with the people we are concerned about. And we literally tell them what I've just said to you, that you want to have this very handy. And in a bad day where you have maybe too many suicidal thoughts, which I want to emphasize cannot be controlled, usually they cannot, you want to have that, like, should I say, on your fridge or your bathroom mirror, because you want to look at it. And it starts with the warning signs. What can trigger my suicidal thoughts? Usually people know that, people who suffer from suicidal thoughts, they know that. It could be my wife was screaming. It could be my neighbor was doing whatever they were doing again. It could be, my child was doing ABC. People know the warning signs. People can tell if you ask them what happens before. It's usually particular events, not to blame. Triggers are not reasons, but they're triggers. And then really, you need to take your mind away from this. This is kind of the first thing that you can do with yourself, hopefully by yourself. And how can you do it? So step 2, can you distract yourself and you don't need people, right? Let's say you don't have access to people. Is it the TV? Is it the radio? Is it walking? Is it cooking? And you really want to help the person, come up with what they would do. What do they think they would do to distract themselves that is feasible to them? That doesn't work always. And then you want to have someone else that can distract you, another human being. But you don't necessarily want to share with them, this is what's going on. I'm having suicidal thoughts. So who are the people you can call or contact or go to visit, and they will just talk about, call it the weather, call it nonsense, call it about themselves, but it will distract you and calm your mind. And you actually want the person to write that down with names and phone numbers. Step 4, these are the people that you actually can share with them that that's what's going on. Listen, this is what's going on. And they will, will able to speak with you about it directly. They're not professional people yet. They're one step before then, but you can share with them openly, this is what's going on in my mind, and they can have a conversation about that with you. And many times that's what people do when they don't have access to professional people. As we know, not everyone has access to their therapist because they don't even have one. And then step five, of course, is professional help. And you want them, the names, the numbers, if there is a suicide prevention lifeline, you want the number there. This all has to be very, very detailed and handy in time of need. I'm seeing something in the chat. Oh, good morning, Michelle. Stigma. I want to mention stigma because somehow it's very much related to suicidality. Now, the stigma doesn't necessarily have to do with I am suicidal. The stigma can be about something completely different. It could be about my gender. It could be about the fact that, I've been in prison. It could be about my color of skin. Stigma can be just about anything. Unfortunately, it's something that exists in the world, as we know. I'm almost saying it cynically, as if we didn't know. But in psychology, we take this very serious, and we even have 3 levels of stigma. The first is an acted stigma. That's actually the stigma that exists. Usually there is such a thing called stigma, and people in this society do create it in different ways and forms. So the individual, whoever that is aware of it. The second level of stigma, we call it felt stigma. So I'm aware this exists and I feel it. When someone says something about my gender or color of skin or anything else about me from that unfortunate perspective, I feel something inside me. But the level which really concerns clinicians like me is what we call internalized stigma. At that point, whatever stigma it is, it's inside me. I think, it's part of me. The stigma became part of me. And there are not, unfortunately, too many people who walk like that in the world. And so whatever parts of society are doing to them, and, some of us are trying to prevent that, it doesn't matter anymore. There is an engine inside that does it. And that's a very dangerous thing. And that is actually very much related to suicidality, often enough. Okay, in the time that I have, which I'm going to glance, I don't have that much time. I'm going to, now that I've went through the assessment, I'm going to give you 3 theories in psychology, which I think, one in psychiatry, actually, a psychiatric one, actually 2 in psychology, a psychiatric theory, and then the 4th one tries to integrate everything together. But the theories actually allow us to assess it, to assess the issue of suicidality in a deeper level, and also how to treat it. And just to say, just kind of the 4 bullet points here that you see. There are suicidal thoughts. There is a level of intensity of emotions we are going to discuss. And there is a component of impulsivity that we are also going to mention. And there is a narrative. The person can explain to themselves why they're doing it at a particular tragic moment that they are doing it. Okay, Escape from Self-Theory by by Roy Baumeister. That has, it's not a recent one, but I think it, in many levels, it captures a lot of psychological issues that happen. First, there needs to be some kind of a severe experience that the person goes through, and it has to be fall far below the standards of society, or it's far below the person's own standard. So when we read those horrific stories of, a man came to the kitchen, shot his 2 children and killed them, shot his wife, she is not dead, and then shot himself. So, you know, this is extreme, but this is far below. And the fact that this individual shot himself from a psychological perspective, again, I'm not in any legal stance at the moment. From a psychological perspective, whatever just occurred, and probably there were things before then, are way below what he considers to be the standards. And then for a suicidal to occur, the person needs to be thinking, feeling that they are the one to blame, and it's their self that created all this. And then what happens, and this is very psychological, once that happens, any what we consider a higher self-awareness of who I am as a person, and what are the circumstances, what did I just do, or what did I just did, are just one cannot go there anymore. A person at that point cannot be using whatever they consider or we consider their high level of awareness. So they need to start escaping their own level of awareness. And, you know, in conjunction with those horrible, horrible, intense negative emotions, which could be guilt, which could be fear, which could be anger. So at that point where the person wants to reduce their self-awareness and they want to avoid and escape their emotions, their negative emotions, they are actually in a place where there is no meaningful thought running in their mind. And it's what we call, and this theory calls a numb state of cognitive deconstruction. I'm quoting this social psychologist. So you need to escape. You need to escape, and that's where you are. And from that place, this numb place, impulsivity kicks in, and the person can do what he can do, which is end their life. So it's what really this theory says is, you know, any intervention to assist such a person is to help them not escape themselves. And that means we better meet them and help them years before, as you can tell. I mean, the more we're getting to that bottom line, there is a point where the person from a mental psychological perspective is not there for us to do something about it. So this is why all interventions need to come much, much earlier. So that's one known theory. Yeah, I just put that on a different slide because I think that says it all. The consequences of this deconstructed mental state includes a reduction of inhibitions, which may contribute to an increased willingness to attempt suicide. We cannot have such a presentation without talking and mentioning the known, we call it the father of contemporary suicidology. I hope I'm pronouncing it correctly in English, Edwin Schneiderman. He's really one of the first theorists and researchers who did not shy away from this topic. I could spend a few hours talking and showing how history tries to not deal with this topic in different ways, forms, and shape. But at least in this era, this person was not ready to go for that. And he, most of his professional life, he spent reading letters, notes, anything that people who ended their lives, unfortunately, left behind. And his bottom line message was, it's a horrible, horrible psych ache, an intolerable psychological pain. And I think it's very important to remember because, you know, when people tell us that they want to end their lives, we are so busy, like into the, you know, kind of, okay, how were you thinking to do it? Let's not have gun at your home. Where do we have to lock you? But we can never forget, and we shouldn't forget that this individual is in great pain. And also what Edwin Schneiderman emphasized is the ambivalence, the ongoing ambivalence whether to end one's life or not, which is for us, that's always what makes me hopeful when I work with people who are unfortunately on that track, is that I always remind myself that there is always a level of ambivalence. And he's one of the folks who said just by having a letter there that still communicates what was going on, we show that. So that's worth mentioning. Another theory, which is a very neurological theory by Dr. Mann and other folks, are actually in our institute. And that's, I think, current Western psychiatry holds to that theory. And that's what's called the stress diastasis. Oh, I wish Judy would say it instead of me. And that's really that the particular brains have a tendency toward aggression, impulsivity, or hopelessness. Of course, when psychologists like me hear it, we are like, oh, give us a break. Because what about the context? What about the stressors? What about the psychosocial crisis that the person is in? What about the traumatic family background this person had? Why are you talking to me about the brain? Well, just to do justice to this theory, the theory is very aware that there needs to be a context of all the things that I've just said, plus that vulnerability in the brain. So you can ask me, why mention that? What can we do about the brain? We should do everything about the other variables that I've just mentioned. Well, the answer is that in today's psychiatry, there are attempts, and hopefully they'll be successful, to intervene on a brain level. So what do I mean by that? If in a particular family, one of the partners is abusive and the other is being abused, and that probably has to do with post-traumatic stress disorder that maybe both of them have, and their level of living is unbearable, and they need a lot of resources from the community, and they need help and funds and jobs and all of the above, and maybe help them parent their children because they're not doing well and they need to heal themselves. But if one of these two people that I've just mentioned is having suicidal thoughts, Western psychiatry would say, well, maybe there is also a brain vulnerability. Well, can we treat that? So this particular individual who deserves to get all this help, can we strengthen their brain so they won't get to end their lives? So I'm just doing my best to actually present the more psychiatric position or perspective as I said before, we need a whole village to help a person not to end their lives. So maybe there can also, not only, but also be an answer from that place or from that perspective, part of the answer. The last theory that I want to present to you, do I still have a few minutes? I want to think that I'll do. I'll just zoom through it. This theory is by Thomas Joyner. It's a more recent theory. By more recent, I mean 2005. But it really integrates well some psychosocial, psychological, and also physiological aspects of suicidality. Again, he also studied it by whatever was left after people ended their lives. And he has some very tragic, fascinating video selfies that people did, which ones I had the opportunity to see. I'll share it with you in a moment. He basically said that there needs to be two psychological factors. The person needs not to feel belong in horrible ways. So no sense of belongingness. This is the circle on the right. whether it's the community, the family, the partner, the world. And then there needs to be also a very high level of sense of burdening others. And again, if you see it, these all somehow overlap. I mean, at that point, you can use the theory of escaping the self that I mentioned earlier, or the psych pain that I mentioned, but I think he captures this all. And then, he talks about the having a suicidal desire, and which you see above, and then the capability for suicide. That's probably where the theories about the brain would enter, and that is that the person, from a brain perspective, reached this point of, and he actually emphasizes very low fear of pain, very low fear of pain. And he showed us someone who taped themselves a few minutes before they shot themselves in the head. It's one of the worst things I've ever seen. And interestingly enough, if we usually, like I just been talking, hopefully looking at the camera, we wink our eyes every once in a while. He noticed that people who leave those tapes just before they end their lives, they never wink. They just never wink. And that kind of indicated to him that something happens to the brain. We always think about impulsivity. He's suspecting, and that's based on some studies that he's been doing through the years, that it's something about the fear of pain. Just it's gone, but it's gone from a physiological level. He thinks that not moving the eyes indicates that. But I want you to look at the red here, the red square, which is a lethal suicidal attempt. I mean, you need to have something to kill with. That's, I cannot talk enough about, if all this would have happened, but the person didn't have any access to something that they can end their life, they would have not ended their life. So, it just brings to mind, in some ways it brings to mind, let's maybe lock those people down to save them, but there's a lot of issues with that, and they're often enough don't get the care that they need when they're locked down. This is, if I still have 2 minutes, this is based on this theory. It's called the 3 steps theory. Are you in pain and hopeless? If the answer is yes, most likely you have suicidal ideation. Does your level of pain exceed your connectedness? This is much more grabbing. And there are many ways to ask this, of course, than your sense of connectedness to anyone. It can be even your connectedness to your dog or your cat. When you sit in front of a person, you won't ask them if they're connected to their partner, if they have a girlfriend for the last 2 weeks, right? But you will wonder, and you will try to see if they may be very connected to their parent, or very, very connected to their pet, or who potentially they can connect to, and you want to assess that. And if their pain, the way they express it, exceeds that, you can count on them having strong ideation. And then this simple, eerie question, do you have the capacity to attempt it? And there are many things that can be asked here. I think I want to wrap up. I don't know if I was supposed to leave questions. I wish I did. I was just talking and talking, but there's so much to say about this. So yeah. Oh, I didn't go into all the practical ways, Judy, how to help. Let me just, give me 2 minutes. 2 minutes. This is kind of the summary of what I was talking about, the escape, less and less communicating because of that mental brain state you're in, the environment that stops, you're disconnected from the environment, and your unbearable state of mind. And then I was just going to a little bit describe what I call first level interventions. And we know that cognitive behavior therapy can be very helpful in actually reframing the suicidal thoughts, hopefully when they're still not so intense. That usually, as you can see from here, can decrease the negative emotions. We can do some behavioral changes, which could be watching TV instead of letting your suicidal thoughts overcome you. That's, of course, if you're in at the beginning of this path. And physical sensations, we do a lot of work with people. What are the physical sensations that they feel? Hopefully weeks and before. These are my funny way of looking at distortion thoughts. We'll do it another time. Dialectic behavior therapy, which is a kind of came out of CBT with some mindfulness, Buddhistic traits in it, and basically it's helping the person think of themselves as different minds and the different techniques that they can help themselves. This works more on the emotions, thoughts, but most on, kind of distressing, reducing intense emotions. So the emphasis is there. I'm sorry, I cannot describe it more. And interpersonal therapy, I know Dr. Elena Verdelli that has brought IPT to many parts of the world. She's magnificent in doing so. I know she's giving a talk in this convention. And it's basically, beside reducing symptoms of emotional intensities, it's also to directly work on your interpersonal problems, because as you could see through my talk, if the person is still connected, hopefully to people, but I will take pets also because that saved many people's life, I can assure you, then we can prevent this tragic end result. And anything that we can do as part of a group or community, or reaching out and touching someone, as my slide is trying to show. And thank you, everyone. Appreciate being here.